Good afternoon once again, everyone. Wherever you're joining in from, whatever time zone you're joining in from, it's in the afternoon here in Nigeria, so good afternoon. We're basically trying to create much needed awareness on some conditions that is affecting us, not just in Nigeria or Africa, but worldwide. Um, January is a month, although we're in February now, but January is a month for thyroid awareness, and this is a medium to help push that narrative. My name is Dr. Anye Emmanuel Usochukwu. I'm a critical care physician and anesthetist at Chiron Hospital and ICU, and I'm here to give us brief overviews of thyroid disorders. Why I say brief is because thyroid disorders are quite numerous, so I'll try to see how I can compact everything in one presentation and give us the most important things as much as possible. So, before we go into the thyroid disorders proper, I want us to understand some facts. First off, on a global scale, you've got over 200 million people suffering from thyroid disorders, and 50%, basically half of those people, are undiagnosed. And when you don't have a condition properly diagnosed, it puts you at risk of developing complications. In this case, for thyroid conditions, you develop complications that are associated with the heart, with your bones, or with infertility for women most times. And it's said from statistics that women are 5 to 8 times more likely to have the condition than men. It does not mean that men cannot have the condition. However, women have more predominance when it comes to developing the disorder. Then 1 in 8 women will develop a thyroid disorder during their lifetime. That's quite significant. And up to 60%, like I said initially, are unaware of this condition. And just like I said, and just like every other condition out there, early detection, if you detect this disease early, it helps to prevent complications, and you tend to, have careful management of the condition at the end of the day. Now, as a way of introduction, we're going to, just like every condition that happens to the human body, we need to understand this thyroid disorders, where does it originate from? What particular gland or what particular organ are we talking about? So we will talk about the anatomy, go into the physiology, talk about its functions in the body, before we now talk about the pathologies that might arise from the dysfunction of that organ. So the thyroid gland is if you can look at the slide, it's a butterfly-shaped organ that is located at the anterior aspect or anterior region of our neck. It's the largest endocrine gland. Endocrine glands are glands that secrete hormones in our body. So it has 2 lobes, the right and the left lobe. And histologically, it has 2 cells, follicular cells and the parafollicular cells. And I'll tell us why those cells are important as we go in the presentation. Then the next thing to talk about is the blood supply, nerve supply, and lymphatic drainage of this organ. Basically, we're talking about how or what keeps this organ working regularly or functionally. So it's supplied by the superior thyroid artery and the inferior thyroid. This is the superior thyroid artery there, and then the inferior thyroid artery going from below. It's the same name. Veins also drain blood from the thyroid gland back into the systemic circulation. So the superior thyroid vein and the inferior thyroid vein, here you have the superior thyroid vein on this end, and then the inferior thyroid vein. These are the major tributaries or branches of vessels that goes through the thyroid gland. Then for nerve supply, we have 2 major nerves that innervates the thyroid gland. So you have the recurrent laryngeal nerve, which is a very important nerve when we talk about surgeries bordering around thyroid gland, and then the superior laryngeal nerve as well. Then lymphatic drainage, lymphatic system is like, I call it a gutter system where waste products pass by. So for the thyroid gland, they have the lateral deep cervical lymph nodes, and the pretracheal and paratracheal lymph nodes. So basically, these are systems where whatever waste that has been generated from the gland, passes by and then goes through the body. So the next thing to talk about is the physiology. How does the thyroid gland work? What is the way, in which this gland performs its function, and why is it important to us? So the first thing to understand is that the function of the thyroid gland, or the main function of the thyroid gland is to produce hormones. Two hormones in particular, the thyroid hormones and another hormone called calcitonin. But for that, specifically, the brain. Hello, can you hear me? Am I audible?
Yes, I can hear you. But can you be able to be more audible?
I saw a notification that my internet is fluctuating. So, okay, so yeah, basically the brain, a center in the brain called the hypothalamus. Okay, yeah, so a center in the brain called the hypothalamus would secrete a hormone called thyroidism hormone to the thyrotropes. That's like a center in the brain there. That stimulates another part of the brain called the pituitary gland, anterior pituitary gland to be precise. So that produces thyroid stimulating hormone, which goes down to the thyroid gland, which is located at the neck, to stimulate the thyroid gland to produce thyroid hormones. That's thyroid, iodine, thyroidine, and then thyroxine itself, and as well as calcitonin that I mentioned. Obviously, there are a cascade of events that happen before the production of thyroid hormones and then the calcitonin. But basically, this is what happens. And this is important because there is this, going to the next slide, there is a regulation of the production of these hormones. So there's like a negative feedback regulation. Sorry, the slides look a bit jam-packed together, but this basically shows us how the body tends to regulate the production of these T3 and T4 hormones. When they are elevated, when they are increased in target tissues, they send a signal back to the anterior pituitary to tell them to stop producing the thyroid stimulating hormone, and which as well, they also send another signal also to the thyrotropin releasing hormone to also stop stimulating the anterior pituitary to stimulate to produce the thyroid stimulating hormone. So this helps to control or regulate the amount of circulating thyroid hormones in the body. Like I said, things like increased metabolism, if you're growing a temperature, if the person is growing abruptly, it tends to create that negative feedback. And then when your temperature is a bit low, maybe hypothermia, or you're having other stressors, you have a more stimulatory. So you want to increase the metabolic rate of the body. And the thyroid gland is one of the major glands that controls over the total metabolic rate of the human body. So this particular mechanism helps to regulate it when it's low and also increase it when it's high. So then with that said, we come to the functions of the thyroid gland. Like I said, it produces 3 or 2 hormones. We call these thyroid hormones, and then the calcitonin. So you have the T3 and the T4. Predominantly what we have in the active hormone is the T3. However, the T4 acts like a precursor for the T3. So most times the T4 gets to the peripheral tissues, the muscles, the brain, the heart, and whatever, and then gets converted to T3. It basically loses an iodine molecule and then becomes T3 triiodothyronine. While calcitonin, on the other hand, helps to regulate hypercalcemia levels. So when you have high levels of calcium in your body, calcitonin is a hormone that helps to regulate those levels. So it basically helps your body to either break down more bone and then clear out the calcium, tells the kidney to filter out more calcium, so you're pushing out more calcium. Then the parathyroid hormone is a parathyroid gland, and the parathyroid hormone are specifically used to control high calcium levels as well. So going forward, the next thing we're going to talk about is the risk factors. the risk factors of thyroid disorders stems across a lot of things. There are a lot of factors associated with it. You have your demographic and genetic factors, which is one of the most common. And like I said initially, women are 5 to 8 times more likely to develop the thyroid issues. Then there's an age factor as well. So between the ages of 30 to 60 years. However, for some conditions where there is like conditions like hypothyroidism, as one is advancing age-wise, they tend to be at risk of developing the condition. Then also, if there's a family history, a genetic predisposition, definitely that puts one at risk of developing the condition. Then medical history and conditions, like I said, if there are coexisting autoimmune diseases, yes, that would also trigger a thyroid disorder, because most thyroid conditions are autoimmune related. We're going to see that as the presentation goes on. Then if there is a previous history of thyroid issues, radiation exposure, very important, which is why, especially for us in the healthcare sector, we ensure that radiology, we ensure that we use the right protective gears when we're, performing our duties and exposing patients for X-rays or CT or any of these imagings that emits a lot of radiation. Pregnancy is also another condition that can predispose one to having thyroid conditions as well. Then lifestyle and environmental factors, we talk about iodine intake, where both deficiency and excess can put you at risk of having one. Smoking is a risk factor. Yes, smoking causes proliferation of free radicals, which can alter your immune system and then make the autoimmune factor of thyroid disease generate as well. Then medication, there are some medications that are known to affect the thyroid glands. Medications like amiodarone, lithium, they could cause inhibition of the thyroid synthesis, hormone synthesis, which could lead to hypothyroidism. Then stress and injury as well can also trigger thyroid disorders as well. So we need to understand these risk factors. It's important to help us prevent having these thyroid disorders. Now, for thyroid disorders, mainly you have two broad classifications, but there's a third classification. But the most common are hyperthyroidism and hypothyroidism. Hyperthyroidism simply means high levels of thyroid hormone circulating through the bloodstream. Why hypothyroidism is reduced levels of thyroid hormone circulating through the bloodstream. Now, like I said, there's a third one where both the levels of the thyroid hormones are normal. However, patients basically have symptoms suggestive of a thyroid disorder. We're going to see that again as we go to the presentation. Then hyperthyroidism, you see conditions like Graves' disease, thyroid storm, toxic thyroid nodules. Then for hypothyroidism, we have Hashimoto's thyroiditis, we have cretinism, myxedema, postpartum thyroiditis, subacute thyroiditis, and sick euthyroidism. Also, based on lab criteria, we have a classification of how we can categorize thyroid conditions or thyroid states, as I like to call it. So you could have an euthyroid state where the thyroid function levels are actually within normal limits. The thyroid stimulating hormone, the free T3 and the free T4 values are all within normal limits. There's what we call the subclinical and subclinical hypothyroidism and subclinical hyperthyroidism. So basically, in this case, the T4, that's the hormones themselves, are normal for the two of them. But what's different now is that the thyroid stimulating hormone is high for hypothyroidism and it is low for hyperthyroidism. Then hypothyroidism proper, you would have high levels of thyroid stimulating hormone, but low levels of the thyroid hormones themselves. Then hyperthyroidism, there are low levels of thyroid stimulating hormones and high values of the thyroid hormones themselves. So what are the symptoms, or what does it look like having this condition? We're going to still take it one by one, but this is like an overall picture of how it looks like having a thyroid disorder. Hypothyroidism, we should remember, is basically means slowing down of the metabolic rates of the human body. While hyperthyroidism stems or talks about a rapid metabolic rate. So you would have things like cold intolerance, dry hair, puffy face. There, in both cases, there could be a swelling or a mass called a goiter at the anterior part of the neck, which will be explained. Then slow heartbeats, because like I said, hypothyroidism metabolic rate is slow. Weight gain, because obviously the rate at which metabolic reactions are happening are quite reduced. So basically, you have issues with fat metabolism, glucose metabolism, protein metabolism, and then the person tends to, add a bit of weight, constipation as well, and there could be issues with fertility or reproductive health, miscarriages when you're pregnant, or irregular periods as well. The same thing for hyperthyroidism. So hyperthyroidism basically will be the opposite of hypothyroidism, where you have hair loss, heat intolerance, fast heartbeats, weight loss, diarrhea, as opposed to constipation. And then you could have longer cycles where with your menstrual cycles or periods, as the case may be. So with the hypothyroidism, you have an underactive thyroid function. Basically, the thyroid gland is underactive, it's underfunctioning, so to say. While for hyperthyroidism, the gland is overfunctioning. Levels of the hormones are low in hypo, as opposed to hyper, where they are high. Metabolic rate, like I said, is slow in hypo, as opposed to hyperthyroidism, where they are fast. Weight gain is noticed in hypothyroidism. Then there is weight loss in hyperthyroidism. Energy levels obviously will be low in hypothyroidism, fatigue and sluggishness. Then there is this hyperactivity and restlessness with hyperthyroidism. Then the heart rate is slow, and there's rapid heartbeats for hyperthyroidism. Cold intolerance, heat intolerance, like I said, and then mood effects like depression, brain fog. While in hyperthyroidism, you have anxiety and irritability. So let's take some of the conditions that we looked at when classifying thyroid disorders, and we'll start with the hyperthyroidism conditions. And the most common out of all of them is Graves' disease. So Graves' disease on its own is an autoimmune disease. It affects the thyroid gland. Now, in this case, basically what this means is the immune system has in a way been altered. So it's now basically attacking the thyroid gland. However, in attacking the thyroid gland, it doesn't create an inhibitory mechanism. It creates more of a stimulatory mechanism, causing excess production of thyroid hormones. The same thing, like I've mentioned, there is still more predominance of it happening to females as opposed to male. And then it also has a strong hereditary component. And diagnosis most times is made, it's a clinical diagnosis. So definitely when you should get to the hospital, you have a history taken by a doctor. They're going to go through your history, your past medical history, examine you, and most times make it, and then do the laboratory investigations to confirm what they've seen during the examination, and then make a diagnosis of Graves' disease. So clinical presentation, most times, like I said, you will have all the symptoms of hyperthyroidism. In addition to that, there will be signs of a goiter, which is an enlarged, inflamed, overactive thyroid gland. Then your skin might be moist or warm. Tremors might be seen as well. There will be tachycardia, widening pulse pressures, arrhythmias will also be present as well. Then there's always going to be eye signs, or what we call infiltrative ophthalmopathy. So there are different eye signs that will be noticed in patients with Graves' disease. So, and one of the common infiltrative ophthalmopathies that we talk about is exophthalmos or proptosis, where the muscles of the eyes are infiltrated by these autoantibodies that basically damage those muscles and then cause inflammation, making them to pop out, so to say. Then there could be skin signs as well, where we have infiltrative dermatopathy. And this is what we call pretibial myxedema. And that's like the deposits of retinaceous substances at the pretibial region of the legs. So it has the discoloration of the legs, scaling of the leg and stuff like that. So those are basically signs that would accompany the symptoms that I've highlighted initially before of hyperthyroidism. Then in making a diagnosis, like I said, a clinical history has to be taken, physical examination done to assess for all those signs that we mentioned. Then a laboratory investigation will be done, a thyroid function test. The serum thyroid stimulating hormone will be checked. Free T3 and T4 tests will be done as well to confirm the diagnosis. There could also be specific testing, what we call radioactive iodine uptake, where you're giving a small amount of radioiodine. Basically, what it means is that you're giving a substance that you will ingest that could be detected through a scan. So they're trying to see how well the thyroid gland takes up that substance. Iodine is actually concentrated more in the thyroid gland. So this, if it's a hot or cold noodle, it depends on how much of the iodine has been taken up by the thyroid gland. Then they could also test for TSH receptor antibodies. This is specific to Graves' disease, so you need to test for the antibodies to confirm that the condition is actually an autoimmune one. Then a radiological thyroid scan could be done as well. Hello, can you hear me?
Take this call.
Yes, we can hear you. Please go ahead.
Okay. So a thyroid scan can be done as well to rule out any form of malignancy. That's a cancer, if it's a thyroid cancer, or if there is any calcifications on the thyroid gland itself. So for treatment purposes, your physician is going to place you on anti-thyroid medications, basically drugs to help reduce the effect of the thyroid hormones on the body. So these drugs are called metimazole and carbimazole, and the dosage most times there's a loading dose and then there's a maintenance dose of 5 to 20 milligrams, and then maintained with 2.5 milligrams to 10 milligrams daily. Polythyroid is not usually prescribed in this part, but can be given during cases of pregnancies, first trimester pregnancies, or thyroid storm. So it starts a loading dose of 100 to 150 milligrams thrice daily, and then you maintain with 50 milligrams twice daily. So you could also be given medications to control the symptoms, beta blockers to control the fast heartbeats or fast heart rate. You could also be given iodine to also help reduce or shrink the thyroid mass itself. Then the radioactive sodium iodine as well. The surgery could also be counseled upon as well, depending on how big the thyroid gland is. So they could go for either a partial or total thyroidectomy. Surgery most times comes up, or most times the indication for surgery depends on if the thyroid disorder is causing respiratory issues, digestive issues, difficulty swallowing, or basically cosmetic reasons where you don't like the way your neck looks, basically. Then corticosteroids are used for the infiltrative ophthalmopathy to help reduce the inflammation going on at the orbital muscles. We could also do orbital decompression. I didn't put that there, but yes, that could be something that can be done to help control or correct the exophthalmos, the proptosis that might happen from this condition. So the next condition I want us to talk about is thyroid storm. And I'm not sure most of us have heard of this condition before, but for the medical people, I'm sure they must have heard of it. But for the people who are not medically inclined, I'm not sure you've heard of a thyroid storm before. And it's important, I just wanted to put this out there because as an anesthetist, it is important that people know these things and then try to make informed decisions whenever they see or whenever they meet their doctors and they go through their condition. So thyroid storm, as the word or the name implies, basically it's like a storming of all the thyroid hormones, like as a result of something triggering it. So it's an emergency. It's a life-threatening emergency. Basically, it's an acute form of hyperthyroidism, and it happens when either an infection or trauma, surgery, or uncontrolled diabetes or pregnancy. It triggers a high surge of thyroid hormone. So basically, you have someone who is a known hyperthyroidism or thyroid disorder patient, and because the person has refused to properly control their thyroid condition, they go for either a surgery or the life happens and they get pregnant. And with pregnancy comes issues with thyroid dysfunction. And then there's this double surge. You have an uncontrolled hyperthyroidism state together with something that would also trigger a lot of dysfunction with the thyroid gland. And then that causes a storm, so to say, in the patient. So you have heightened symptoms of hyperthyroidism in this case. Most times, it usually happens during surgical procedures. Apart from the normal symptoms of hyperthyroidism, you will have marked weakness, muscle wasting. There will be extreme restlessness, confusion, psychosis. Then the heart could also collapse. Basically, the patient could enter what we call shock, where the blood pressure goes so low, and then that would obviously lead to coma in some cases. Now, like I said, most commonly happens to people who do not control their thyroid disorders, hyperthyroidism states, and then they go in for a procedure or a manipulation. So, in making a diagnosis of thyroid storm, especially intraoperative or perioperatively, what we do is, for when we see the clinical picture, we first need to rule out other differentials. Differentials, what could also cause these things are sepsis. It could be a malignant hyperthermia. It could be a neuroleptic malignant syndrome. It could be serotonin syndrome or pheochromocytoma, or it could be iatrogenic. So once that has been ruled out and you're sure that this is a thyroid storm, this patient is having a thyroidectomy, thyroid function levels are done, and you don't actually have to wait for the results, but yes, this will also help you confirm that it's actually a thyroid storm that is happening. And then you also get the family history, maybe from a relative that, okay, this person has a thyroid disease. You can see an obvious goiter, there's exophthalmos and stuff like that. So the next thing you need to do is, if this patient is awake, you have to either try to create so there's these diagnostic tools to know how to differentiate or how to initiate treatment. So both of those tools, we have the Boltzmann point scale and the Akamitsu diagnostic criteria. So you use those tools to determine when to initiate treatment. But if this patient is under anesthesia, you need to initiate treatment immediately, because most times, if nothing is done, they would end up. In fact, most times the cases are managed in the ICU. So it's important that you initiate treatment as soon as possible. So, and even if the thyroid function levels come out to be normal, don't stop your treatment, don't stop your specific treatment that you're giving. So what treatment do we initiate basically? So what are the considerations you need to have when you're initiating treatment or managing this case? Like I said, it's an emergency, so you have to inform everybody. Let's say it's happening in the theater, you have to inform the team, the entire team in the theater, the surgeons, the scrub nurse, everybody that is there. You, the anesthetist, call for help as well. You make sure if the patient is not intubated or patient is having regional anesthesia, you could protect the airway and give oxygen supplementation. However, if the patient is intubated, you have to increase the fraction of inspired oxygen and then optimize ventilation. Then, like I said, consider differential diagnosis, try to rule out other things. Is it sepsis? Is it NMS, neuroleptic malignant syndrome? Is it malignant hyperthermia? What have you? Then treat the trigger. So if it's the surgery, you have to stop it, like I said. If it's what's it called? If it's an emboli, you have to try and sort that out as well. If the patient has DKA, which is the trigger, you have to correct that as well. That's diabetic ketoacidosis. Then if this patient keeps on having like a repeat thyroid storm, then you obviously have to consider removing the thyroid gland itself, which would be like a high risk surgery because in removing it as well, it could lead to a thyroid storm. So you try to basically weigh and balance the pros and cons basically. Then you also have to sort out complications that could arise from this surge. So liver failure is one of the most common, and then you have to consider giving a fresh frozen plasma or the likes of that. So basically, like I said, so management goals are number one, most times the patient will be convulsing or they might be comatose. So if they're convulsing, you give your sedatives, diazepams, midazolam. You also use phenytoin and also use anesthetic agents like propofol just in case. Then if obviously they will have this high fever, you can use paracetamol. You stay away from NSAIDs because NSAIDs also are known to be triggers in a way as well. So you do paracetamol, you take a sponge, you try to actively cool them. Then you commence anti-thyroid drugs. Propylthiouracil is most recommended in this case. So that can be given, like I initially mentioned. Also, you give beta blockers because apart from the acute symptoms, there will still be signs or symptoms of hyperthyroidism. So you need to control or block the increased adrenergic tones, the propranolol, esmolol, metoprolol, as the case may be. Steroids are also given to help prevent the conversion of T4 to T3 at the periphery. So you can give dexamethasone or hydrocodone. Then you manage the cardiovascular effects, arterial fibrillation, acute heart failure, tachycardia. So you can give your digoxins, amiodarone for the AFib, noradrenaline and dobutamine for acute heart failure, and then also furosemide as well, and then Solor to control the tachycardia. So the other thing we need to talk about is what are the other causes. Like I said, there are a lot of other causes of hyperthyroidism. You have Kilmer's disease, where you have a toxic nodular or multinodular thyroid condition. You have inflammatory thyroid disease. That's where you have subacute thyroiditis or a variant of Hashimoto's thyroiditis. So then you also have inappropriate TSA secretion. It's quite rare, but in this case is where there is a pituitary tumor that is causing a high secretion of thyroid stimulating hormone. Then you have medications which induce hyperthyroidism. Like I said, medications like there are some cancer medications or cancer drugs that can induce hyperthyroidism. So you need to always make sure that you run through your doctors to be sure that medications that you're taking are not going to affect any organ in your body. Thyrotoxicosis factitia is actually when someone consciously or subconsciously takes a lot of levothyroxine, which is the hormone replacement therapy for thyroid, that's hypothyroidism. So this is like sometimes it could be like a behavioral or psychological issue where someone actually intentionally takes a lot of levothyroxine, maybe to just have that heat intolerance or those symptoms of thyroid condition. Then there's what we call excess iodine ingestion. Obviously, that's quite simple, where you ingest a lot of iodine-containing meals or containing foods. Then pregnancy situations, or in women, hyperemesis gravidarum, molar pregnancies, choriocarcinoma. These are also conditions that can cause hyperthyroidism. The hormone produced at this period, that's beta HCG, is known to have mild thyroid stimulating effects. So, and basically at this period, if it's hyperemesis gravidarum, that's early stages of pregnancy, beta HCG is quite very high, highly circulating in the body, and that goes to the thyroid and stimulates it to keep on producing more thyroid hormones. Then we have non-autoimmune autosomal dominant hyperthyroidism, also a rare condition. Some metastatic thyroid cancers too can also lead to hyperthyroidism as well. Although most times thyroid cancers don't have any change on the thyroid hormones per se, but when it's spreading from a different organ to the thyroid gland, it could cause stimulatory effects. Then struma ovari is a form of metastatic or ovarian teratoma, where what's inside the teratoma? The teratomas are basically tumors of the ovaries that contain different content, different structural content because of different genetic or alterations or genetic dysfunction. So in struma ovary, you have thyroid tissue growing inside the ovary, inside that particular tumor. Most times, if you do a radioactive iodine uptake test, you find out that the uptake is more predominant in the ovaries than in the thyroid gland. So yes, it could also cause hyperthyroidism, and we should be aware of that as well. So those are basically all. I think that's basically all the conditions that can cause hyperthyroidism. So the next thing to talk about is hypothyroidism, which is the opposite of it. Now, in hypothyroidism, we look at the insufficient, it means the insufficiency in synthesis of thyroid hormones. The same thing like hyperthyroidism, it has a more predominant female ratio than male. And the causes, the most common is Hashimoto thyroiditis. It could also be iodine deficiency or radioactive iodine therapy. Some drugs like lithium, amiodarone, rifampicin, thalidomide are also known to cause hypothyroidism, and radiation therapy for people undergoing chemotherapy, undergoing oncological therapies could also lead to hypothyroidism. Hypothyroidism is further classified into three. We have the primary, secondary, and tertiary, and this basically talks about the level at which the dysfunction is happening. So for the primary, you have it's sort of the thyroid gland, and primary is divided into subclinical and overt, like I talked about initially, where the thyroid hormones are normal, but the TSH it's high, as opposed to the overt where the thyroid hormones are low and the TSH is high. So then the secondary and tertiary talks about central hypothyroidism, where you have a disorder of the pituitary gland or a disorder of the hypothalamus. So as the image by the side depicts. Now we're going to talk about the most common type of thyroid hypothyroidism, which is Hashimoto's thyroiditis. This was described by Hakaru Hashimoto in 1912. He's a Japanese surgeon. He got 4 participants, and he found that there were lymphocytic proliferations in the thyroid gland of these patients. So, but as medicine advanced forward, there were more papers, and then it was documented that he was the first person that discovered it. It's a primary type of hypothyroidism, meaning it affects the thyroid gland proper, not the pituitary or the hypothalamus. So autoimmune origin, or it stems from an autoimmune cause, and it also has a high female predominance to male ratio, 10:1, affects 4 in 1,000 women per year. So that's quite significant. What are the signs and symptoms? Basically, we have signs of hypothyroidism. There will be persistent tiredness, lack of energy, and all that, like we mentioned before, cold intolerance, unexplained weight gain, constipation, puffy face, enlarged tongue, bradycardia, heavy or irregular periods in women. These are things that would come up from the low circulating hormones, thyroid hormones in the body. So the diagnosis obviously is still the same like Graves' disease, where you take your clinical history, examine the patient, and then you do your testing. In this case, you also test for the thyroxine, the T4, thyroid stimulating hormone, and also test for thyroid autoantibodies, which is very important, like I said, because it's an autoimmune condition. So you need to look for the antibodies or autoantibodies that are attacking the thyroid gland. Then a thyroid scan, ultrasonography, could also be done to also rule out any form of malignancy or cancer. So how do we treat Hashimoto's thyroiditis? Simply by replacing the low hormones. So it's more or less like a thyroid hormone replacement therapy, where we place the patient on levothyroxine. In some cases, it might be for life. That if the condition is more or less permanent, so you might have to take the hormone for life. So at a dose of 75 to 150 milligram microgram per microgram orally once a day, then there could be lifestyle and supporting measures like adjusting your diet. If it's iodine deficiency, ensure iodine intake. So you have to make sure we take our iodized salts and water. Then, if it's a vitamin issue, we get vitamin D and iron, selenium supplementation. If it's stress, we try to exercise, meditate, and then have adequate rest that would help with our stress levels. Then the final one is the simple non-toxic goiter or the endemic goiter. To be honest, it's the most common type of thyroid enlargement, but not really spoken much about because it really doesn't, people don't really talk about it because it doesn't affect the thyroid hormones per se. It has no hyperthyroidism, no high levels of thyroid circulating hormones or low levels of thyroid circulating. Most times, patients with simple non-toxic goiter have normal thyroid function levels. So it's frequently noted at puberty, during pregnancy and menopause. And one of the known causes, or most of the known causes, are intrinsic thyroid hormone production defects. So if there's something affecting the thyroid hormone production, ingestion of foods that contain substances that inhibit thyroid hormone synthesis, we call them goitrogens. Foods like cassava, broccoli, these are foods that inhibit thyroid hormone synthesis. Then medications like amiodarone and lithium as well. So what are the signs and symptoms? Like I said, most times, most cases, it will be asymptomatic. But when the goiters are quite large, it could start causing what we call dysphagia, that's difficulty swallowing, hoarseness of voice, and then globus pharyngeus, that's like a feeling of a heaviness in the neck region. The goiter most times is typically soft, symmetric, and smooth.
Where's the problem?
So diagnosis, still like the other two other conditions that I've mentioned, is still doing the regular thyroid function test. Although, like I said, in most cases, they will come out normal. A thyroid scan can be done just to rule out malignancy as usual. Then a radioactive iodine uptake is also done as well as a thyroid scintigraphy as well. So the treatment, if the person is found to be in iodine deficient areas, they need to eliminate the cause of the iodine deficiency. So basically supplement our salts. We give oral administration of iodized oil. If there are any goitrogens, like the cassava, broccolis, and cauliflowers, that has to be stopped. In some cases, if the patient is having signs of hypothyroidism, you can place on levothyroxine, especially in young people. But this should be avoided in elderly people because it could tend to trigger hyperthyroidism in them. Then if the goiters are quite large, a thyroidectomy is the next line of action to help relieve the symptoms. So speaking about thyroidectomy, whenever you have a thyroidectomy being planned for or scheduled, it has to involve multidisciplinary team of doctors or specialists, which is the surgeon, anesthetist. In most cases, you could also involve the ENT surgeons as well, because if you have large goiters, there are complications that might arise following the surgery or even post-op. Complications like airway compromise, that's a trachomalacia, there could be recurrent laryngeal nerve damage, there could be bleeding or the wound upsides, opening up following the post-op, after the surgery. So it's always important that you have a proper pre-operative evaluation, have the right set of investigations done. Most times the anesthetist will come with you, and that's following the ear, nose, and throat surgeons who would have done a video laryngoscopy just to make sure that there is no airway compromise, that the trachea is patent. They will also do like a thoracic inlet x-ray to check if there are any pressure symptoms on the structures in the thorax. And then before surgery is then scheduled, it is a major surgery. So most times it usually involves most of the senior surgeons on ground. and then it has to be delicately done to avoid any form of complication in trial. So, well, how do we prevent thyroid disorder? So basically, by addressing the risk factors, abstaining from smoking, ensure we have regular thyroid screenings, we have regular thyroid neck checks, we limit soy intake, which can affect our thyroid gland, avoid processed food as well, we reduce stress, and then the intake of required iodine salt, and avoid radiation, which is very, very important. So in summary, preventing thyroid disorders is a multifaceted approach that combines awareness of risk factors, proactive health measures, and informed lifestyle choices. The key practices like using the thyroid collar during x-rays, quitting smoking, having regular thyroid neck checks, dietary vigilance, consistent health checkups, appropriate supplementation, water purification, and maintaining a healthy lifestyle are all vital to ensuring that we control or prevent thyroid disorders. So please, if you have any issues bothering around your thyroid gland, you could actually visit our website or book a consultation with one of our doctors, and you'll be connected to a specialist who will give you more in-depth consultation on your condition. Thank you.
Wow. Thank you, doctor. Thank you for this enlightened education. You really opened our eyes to a lot of things that we don't know that is existing out there. So if you're just joining us, who you heard from now is Dr. Emmanuel Anyeche, who is a graduate of Lugansk State Medical University, a foreign trained doctor, and also has a diploma, West African diploma with Lagos State University Teaching Hospital as well. He's an experienced anesthetic doctor who has a very keen interest with cardiovascular medicine. And as you can see, he's driven about and compassionate about healthcare. That's why you can see how he delivered this. Wow, I'm really, even though I have the idea, but I'm really impressed. Trust me. So if you have any questions, you have certain things that you were not clear about, you also don't understand about thyroid issues, please drop your messages on the chat box. And as you're coming in, kindly mute yourself so we don't have distractions and we could be able to hear one another. Okay, so if you have any questions, please drop your messages on the chat box. We'll answer them. Write them down. If because another doctor is coming up now to speak for us, to speak to us. Also, Dr. Chinonso Ume Ano, I think I'm pronouncing it right. Dr. Tio Chinonso Ume Ano, who is also a foreign trained with NEM Health with HMO. He's also a graduate of Odessa Medical University and has a passion for healthcare and on a curiosity to help people gain healthcare assistance in public health and all. So please, can we give the ground opening for Dr. Chinonso Tio Umano to speak to us on PCOS? Please, doctor, you have the floor.
Thank you, Sandra. Can you hear me? Hello, can you hear me?
Yeah, we can hear you.
Go ahead. Let me share my screen. Great. Can you see my screen? I hope you can hear me and you can see my screen. Good afternoon, everybody. Thank you very much, Dr. Anyage. There's quite a lot of things that... Yeah, there's quite a lot of give context to what I'm talking about. So today, we're also going to be talking about PCOS, or polycystic ovarian syndrome. And this one, unlike the thyroid disorders, this one actually affects women especially. So it's directed towards women health of females. So we'll go over introduction, etiology, and so on and so forth. So let's quickly begin. PCOS, as we know, is a metabolic and hormonal disorder, and it affects women of reproductive age. And when we say reproductive age, we're talking of women between the ages of around 15 and somewhere between 49, maybe 50, right? It is characterized by hyperandrogenism. And when we say hyperandrogenism, we're talking of an excess of male hormones, especially testosterone. Now, we know that women are supposed to have their own hormones, that's estrogens and progesterone, and then men are supposed to have their own hormones, which is mainly testosterone. But then in females, when this progesterone is not actually produced, and we have an excess of testosterone, that is what we call hyperandrogenism. And then it also shows up as ovulatory dysfunction, and we define it as polycystic ovarian morphology. That means when we do something like an ultrasound, we'll actually look at the ovaries and see the morphology, as well as AMH, what we call anti-Mullerian hormone. Anti-Mullerian hormone is a hormone that is responsible for the growth of the eggs. That's the ova that are released from the eggs. If that is actually high, then it's a part of this syndrome. When we talk about globally, we're saying that this PCOS, as we are speaking, affects around 10 to 13% of women globally. That means that in every 100 women, we're getting around 13 that is affected by PCOS, and quite a number of this goes undiagnosed, because of poor awareness, because of poor diagnosis around the world, right? And we are seeing also that the prevalence is actually doubling. And why is this important? Because from a perspective of public health, PCOS is one of the major causes of infertility and ovulatory infertility, and is one of the major causes, or long-term can lead to things like diabetes, things like cardiovascular disease, obesity, and long-term, for people who suffer from this, we're talking of things like depression and anxiety. So how does this come up, right? First of all, PCOS has this multifactorial origin, so we can't really pinpoint this is where this thing comes from. But we've seen over time that there is a genetic link to it. So for people who have PCOS, there's this high tendency for their generation to also develop PCOS, up to 70%. Then there are also environmental triggers that are noticed, like diet, obesity, the sedentary lifestyle, and all that. And then we also notice that there's hormonal dysregulation, especially for insulin. There's resistance to insulin that goes on in PCOS, as well as the dysfunction of the brain and the ovary axis. And when we're talking of brain and ovary axis, we're talking of the hormonal axis between the brain and the ovary. Dr. Anya here talked about the pituitary gland, and it is one of the glands that secretes hormones that is responsible for the production of what we call LH and FSH. LH is luteinizing hormone, and FSH is follicle stimulating hormone. These hormones are important for women when we talk of the monthly cycle and we talk of pregnancy. Now, when there's a dysfunction in this, it is one of the cardinal signs of PCOS. And then one of the major things that we notice in PCOS is also insulin resistance. Now, if you've been in a discussion when we're talking of diabetes, you know that one of the cardinal signs of type 2 diabetes especially is insulin resistance. So we also find that here, insulin, when it is resistant, when we say resistant, it means that the cells are not accepting insulin. Normally, insulin is responsible for reducing the level of glucose in the body. And what it's supposed to do, the cells are supposed to accept glucose because of the function of insulin. But when the cells are not accepting this function of insulin, the insulin just continues to circulate in the blood. And as it circulates, what happens is it continues to stimulate the ovarian cells. It continues to increase androgens, especially testosterone, and continues, that whole cycle continues to worsen the symptoms of PCOS, especially anovulation and the lack of the monthly cycle. How do we diagnose PCOS? Right. So what has happened is that over time there has been consensus meetings and meetings and meetings to say, okay, these are the criteria for us to say this person has PCOS, and we kind of differentiate for adults and for adolescents, and there's a reason why. Right. For adults, there needs to be two of the following. So any two of the following criteria is it means that this person has PCOS. First of all, there needs to be clinical or biochemical hyperandrogenism. So when we say clinical, we're talking of, we are seeing this person having symptoms of hyperandrogenism, or they take the blood and they test for testosterone, for the levels of testosterone. Also, usually this kind of diagnosis will involve a very, very detailed history. So over time, if we take a history and we find out that this person, experiences irregular or infrequent monthly cycles, then it's one of the diagnostic criteria. And then, of course, polycystic ovaries, we do an ultrasound, we might see, the ovaries, in a certain kind of morphology, or we do a test for anti-Mullerian hormone of the blood to see, to check out this condition, to check out this criteria. And this is after ruling out certain other conditions that could mimic PCOS. Certain other conditions like Cushing's disease, like Dr. Anya here mentioned, hypothyroidism is also one of the things that could show up symptoms like this and could mimic PCOS. Therefore, adolescents, one of the both of the features must be present. First is irregular cycles, after taking a history from the time the person started having their monthly cycles. And then, of course, the biochemical or clinical features of hyperandrogenism. And one thing we want to, emphasize on this point is that diagnosing early can ensure that somebody gets help early enough and can prevent long-term health risks down the line. So how does this thing come up? How do we know that somebody has PCOS, right? There are clinical features and we differentiate them into reproductive features. So first of all, the person would have irregular or absent menstrual periods. If somebody is noticing that their menstrual periods are just irregular, that means it comes 1 month and then maybe for 2 months it doesn't come, and then so just irregular monthly periods. Monthly periods are supposed to be a 30-day kind of cycle, right? But if that is irregular, then it could be PCOS, and it's something that you need to check out. If there is absence of monthly periods at all, that is, the monthly periods are not even coming at all, then that could be another sign. And then, of course, there could be the risk of endometrial cancer due to the absence of periods, due to the anovulatory cycles, because the period not coming doesn't mean that the cycle is not going on. It's actually going on, but it's not just showing up normally. Then hyperandrogenic features are what we would, you'll be more used to these ones. You might have seen these ones. You might have been aware of this. When you notice that somebody has male pattern, especially for a female, male pattern hair distribution. So this, like you're seeing in the picture, this person has, more hair than they should have, right? Acne is another one. Acne is what we call pimples. Dermatologically, we might, we describe them differently, but acne generally is what we call pimples. And then this person has oily skin and also has what we call female pattern hair loss. So for hypoandrogenic features, what happens is that the person begins to lose hair like a male, and is actually a pattern. There's a distinct pattern that is different from males. So males, we tend to lose hair from the front, but for female pattern hair loss, it's just right there in the center. And a lot of times it doesn't lead to total baldness. It's just hair loss, just hair thinning out. All right. So these, if you experience this, or somebody that experiences this, then it could be a sign of PCOS. And there are also metabolic features. So people with PCOS tend to have insulin resistance. They also tend to be obese. it's not as if there are no lean people with PCOS, but majority of them tend to be obese. And then, of course, there's this increased risk of type 2 diabetes. So their blood sugar doesn't tend to be normal, under normal. It tends to be borderline or a bit high. And then, of course, there will be psychological features because, as women, there's this feel that you want to have. There's this look that you want to have. So when you're not having your monthly periods, when there's infertility, or when, the hair growth or hair loss is there, it tends to affect, their own psyche. It tends to affect psychologically. So usually there's something we all also notice: anxiety, depression, and of course, lower quality of life as a result of that. Okay, so how do we manage PCOS? If we notice that this person has been diagnosed of polycystic ovarian syndrome, how do we manage it? The first line, usually the initial recommendation for a lot of people, and this is based on research, for the fact that, lifestyle changes have shown marked improvement in things like insulin resistance, in things like weight improvement, and in things like the monthly periods becoming more regular. So weight management and prevention of weight gain is a major recommendation for people with PCOS, right? In regular exercise, is something that is difficult to start, but over time is best for you. That means it improves the general health outcomes, right? So regular exercise has been shown to improve insulin sensitivity. So now it's not like we're giving you general health advice and say do exercise, right? Because I say it a lot in a lot of my talks. If you've been in quite a lot of my talks, I give exercise as a general health, wellness improvement program. But in the case of PCOS, it's kind of like therapy. It's kind of like something you should do, knowing that this is the outcome that you would get. And then healthy dietary patterns are also kind of recommended in PCOS to ensure that people, get back their lives and improve their outcomes. Then there's also there's a place for pharmacological management. In cases where there's menstrual irregularity, we can recommend what we call combined oral contraceptives to ensure or to help this person experience more regular menses. Then for insulin resistance, usually metformin. People who are diabetic will know metformin is usually the first line medication when it comes to diabetes. In this case, we use it for insulin resistance because it helps to improve weight gain, it helps to improve metabolic balance, and it helps to improve blood sugar. And then we can give anti-androgens in severe cases of hirsutism and acne. We can give anti-androgens to help kind of improve the look, help kind of improve the person's morale and psyche. And then, of course, if there is a need, or if this person with PCOS is trying to get pregnant, then there are inductors of ovulation that we can prescribe, like clomiphene, to improve fertility, to help this person actually, experience pregnancy and childbirth. And then long-term management, we know that, people with PCOS tend to suffer from psychological issues like depression and anxiety. So, we look at mental health and support as part of the therapy, as part of long-term management for people with PCOS. So there's psychological care, and then we need to monitor them for diabetes, for cardiovascular disease, for sleep disorders, and so on. And for people, for females who are trying to get pregnant, they have this reproductive planning is part of the therapy, is part of what we have to discuss with them, as they manage their condition. Then, we talked about thyroid disorders, right? And we're also talking about PCOS. So the question is there a connection between the two of them? And in reality, there is, because hypothyroidism tends to a lot of times complicate PCOS, especially hypothyroidism. It tends to complicate PCOS. We're talking of things like Dr. Anya here mentioned, things like Hashimoto's thyroidism and hypothyroidism and subclinical hypothyroidism. Now, what happens in both of them is that so somebody with PCOS that has hypothyroidism has worse metabolic profile. So their BMI will be higher because of what hypothyroidism does to the body. It kind of slows down metabolism. So the person would tend to gain more weight. There's worse insulin resistance, and there's more severe, in this case, there's more severe dyslipidemia. So the lipid profile will be all over the place, right? And then there's a higher reproductive impact. So prolactin and thyroid stimulating hormone tend to suppress ovulation. So there's going to be heavier menstruation if there is, or totally anovulatory. That means no menses at all, or, very, very irregular menses. And then higher androgen levels because of the function of thyroid hormone. The hirsutism and the acne are going to be worse. And then we find that when we correct hypothyroidism for somebody who has PCOS, right, it can improve the outcome. So, that connection is there to help us understand just that, we're not just talking about thyroid disorders, because thyroid disorders are, strongly hormonal. And then PCOS also is strongly hormonal. So you see that managing one tends to kind of help the other. Then when we talk of hyperthyroidism can also complicate both the diagnosis and management of PCOS, right? Because the symptom overlap is there. Hyperthyroidism can lead to menstrual irregularities. So if somebody has hyperthyroidism and has PCOS, it's something that we need to think about. We need to, as clinicians, we need to think about it that, this person might have hyperthyroidism along with their PCOS, and it's something to look out for. It's something to actually test for. There could be anxiety, palpitations, one of the cardinal signs of hyperthyroidism, and all this could complicate the diagnosis of PCOS. Also, the metabolic impact is there. So hyperthyroidism tends to cause weight loss. So hyperthyroidism tends to cause weight loss, right? And in PCOS, there's usually weight gain. So that could potentially mask the diagnosis of PCOS if somebody has hyperthyroidism. And then, of course, people with Graves' disease have this. It has been shown that people with Graves' disease may developing PCOS. And when we say people, we're talking of women with Graves' disease. So just to summarize, PCOS is common. That means about 10, in 100 women might experience this condition in their lifetime. And a lot of times it goes underdiagnosed. So this kind of discussion is just to bring it to the fore, to say that, look, this thing exists, it's there, it's manageable. It's quite manageable. So it's very good that, we're all talking about it. If you know somebody who might have these symptoms or is experiencing these symptoms, then it's good for them to talk to their doctors, because, managing PCOS is not just something that one doctor would manage. You will need a team of doctors. You will need an endocrinologist. And then because they are women, you will need at least this condition. It affects hormones, it affects metabolism, it also affects fertility. So it is one of the highest cause of infertility, especially anovulatory infertility. And down the line, it can have poor mental health outcomes as well. Diagnosing it is based on certain criteria. So once we see those criteria, it's usually straightforward for us to say this person is dealing with PCOS, right? Management, like I said, requires multidisciplinary care. Lifestyle modification is the cornerstone. It's kind of like part of the therapy. It's kind of like part of the drugs, the pills you would take. Lifestyle modification is therapy for PCOS, right? And the symptom and management may be complicated by thyroid disorders. So it's good for us to know that, there is this link between thyroid disorders early detection, when we detect early enough, especially if the person is young, if we detect early enough, we can improve long-term outcomes, not just long-term outcomes in terms of giving birth, but long-term outcomes in terms of how the person feels about themselves and their health in general, because of the development of both heart disease, diabetes, and so on. Thank you very much for listening.
Wow, nice one, nice one. Please, can we give it up for them? We've heard from our two specialists about thyroid disorders and as well as PCOS. And I hope we are going home with something today. Please, if you have any questions, like I said earlier, kindly drop them at the comment section at the chat box and we'll attend to it. But meanwhile, we already have some questions coming in, and I would like us to discuss about it. Please, doctors, are we ready?
Yes, yeah.
Okay, so there is a question here um for thyroid issue. One of them is, why are thyroid disorders 5 to 10 times more common in females than in males? We said it's both gender, but however, it seems to be more in females than in males. So someone is asking, why is this so? Please, Dr. Emmanuel.
Okay, so I should take them one by one, or you want to run through all the questions?
Okay, please answer that, then I'll come in with the next question.
All right, so yes, thank you for the question, Dr. Sandra. So basically, it's quite simple. It has to do with a complexity between the female immune system and the autoimmune regulatory dysfunction that happens with the female immune system. So naturally, women on their own, or females on their own, cause through a lot of things as they go in life. Number one, when they attain menarche. Menarche means when they start menstruating. Puberty, sorry, I forgot puberty. So puberty is there, menarche is there, pregnancy, you now have menopause. At all these different levels, there are changes, there are alterations in their physiology, and these alterations tend to affect their immune system.
Please, can you speak up? Please, can you please speak up a bit? Someone is saying they can't hear you.
So I was saying that what happens, or what makes it more predominant in the females than males, is basically because of their hormonal and immune complexities. Now, when you look at a woman passes through a lot of things in life, starting from puberty, menarche, pregnancy, menopause. All these conditions causes physiological changes. It causes different physiological alterations, which affect their immune system. Now, naturally in a female, their immune system is quite vigorous or quite reactive. So if anything happens, the immune system tends to, swing into action to try to sort it out. So that tends to push them, or tends to put them at risk of developing autoimmune condition. It's not just thyroid disorders. Most autoimmune conditions are more predominant in females than males because of this same thing that we're talking about, them having that highly reactive immune system. Then when you talk about the hormones, the estrogens and the progesterones, estrogen on one hand predisposes them to developing hypothyroidism, while progesterone on the other hand predisposes them to developing hyperthyroidism because of the stimulatory and inhibitory effects they have on the thyroid gland. So these things, basically, you have, like Dr. Chinoso mentioned, for PCOS, you have conditions where the male hormones are more predominant in the female. So, but in this case, estrogens and progesterones are the normal sex female hormones, and they are known to cause different alterations in the thyroid function as well. So that's basically why there is that high prevalence in female as opposed to male. Thank you.
All right, thank you for that clarification. I also have another clarification, please. What does iodine have to do with thyroid disorders? I saw somewhere you mentioned it on one of your slides. So, is it possible you can
Yeah, so
shed more
thank you
light?
so much. Yeah, thank you for
Okay.
that. So basically, iodine is very important. And I think I mentioned it in the presentation that excess of it or a reduced amount of it could affect the thyroid gland in either hypothyroidism or hyperthyroidism. Now, when we ingest iodine from our food, from our water, it gets it's taken up by the thyroid gland, and then when it gets there, it gets what we call it goes through a process called organification. It becomes organized, so it becomes like an organic iodine, and that becomes a substrate for the production of thyroid hormones. Because when we go down the physiology that I presented earlier, we look at where I mentioned the monoiodothyroidines, that thyroxine, and the diiodothyroxine. These are basically thyroxine molecules that have had iodination. It's called iodination. Basically, they have iodine added to them. So when you have monoiodine, that's just one iodine molecule, and then when you have diiodine, that's two iodine. So when you combine those two, you have the hormone triiodine, that's T3. And when you combine two diiodine molecules, you have tetraiodine thyroxine, which is thyroxine itself, T4. So basically, iodine is very important, which is why when you go to areas where there is a form of iodine deficiency, these people are predisposed to developing the endemic goiter that we talked about earlier. So iodine is a very important nutrient, to thyroid disorders, and we need to make sure that our waters, our food are properly supplemented with this particular micronutrient. Thank you.
Thank you for this clarification. So that is to say, women are really bundled with a lot of things. Like you broke it down from puberty up to menopause. We have been going through pains. But trust me, if you ask me my next word, I want to still be a woman, regardless of all of that. So please, can I have some clarification with Dr. Chinonso? I have a question for you. So please, everyone, if you have your questions, drop them at the chat box. I will attend to it. Okay, Dr. Emmanuel is still standing by, but please can we have Dr. Chin also take some questions from me? Why do many women with PCOS struggle with irregular periods or infertility? You mentioned in your slide that is one of the leading cause of infertility. So please, Dr. Chin also, can we shed more light on this?
Okay, thank you, Dr. Sada, for that question. So, what happens in PCOS really is that the cycle for the release of hormones that control the periods, the monthly periods, is broken. From the brain to the ovaries, there's usually hormones that are secreted that are responsible for the maturity of the egg and the secretion and the release of the egg. Because what happens in the monthly period is that the egg is released. There's a hormone that regulates that. And when that egg is released, it's supposed to be fertilized. But if it is not fertilized, what happens? It then, the whole process then goes down, right? And comes out as that's what we see as the monthly period. But in PCOS, that hormonal cycle is broken. Do you understand? So the actual, release of the egg doesn't happen. And that is because of the high level of androgens in that particular disorder. So there's a high level of androgens. Actually, what happens is androgens are first produced and they are supposed to be converted into the estrogens and progesterone, but they are not converted. And because they are not converted, they are not available to do the work that they are supposed to do. And that causes the break in the cycle. So women with PCOS, there won't be that normal cycle of release of the egg and, and preparation for pregnancy. And when that doesn't happen, then, that's what we call anovulation. So for some women, it will be irregular. So, it's not enough. So the stimulation is not it doesn't happen as it should happen. So you have irregular cycles. And then for some women, it's not just there. So you will have an ovulatory cycle. So a cycle where the egg's not released, the monthly flow doesn't come, and then cycle just goes on and on again, just because of that break in the presence of the hormones.
Thank you, Dr. Pino. So someone is asking on the chat box, can letrozole make her pregnant? Please, can you shed the light on this?
And what?
There's the medication you wrote out on the management. One of them is letrozole.
Okay,
so
yes.
she's asking if it can make her pregnant.
Okay, yeah. So that is one of the hormones the drugs that we use to treat the cycle. So it helps to boost this cycle to ensure that the egg is released and, pregnancy can occur. Now, I won't say that it can directly make you pregnant. It's actually a therapy. So letrozole is just one of the mechanisms that we can use to get you pregnant. What should happen is that you should work with your endocrinologist and your gynecologist to ensure that you get, the right therapy. You understand? It's not just one pill that you take and you get pregnant. It doesn't work like that. It's, medicine is not magic.
Second part of her question is, I think she wants to ask, how does she know whether she has PCOS or thyroid disorder? How do you differentiate it? Because you mentioned they have a connection, I think, a link. So now,
yes, great.
Well, that no differentiate either this or that.
Great. Now, usually in PCOS, the cardinal signs are things like hirsutism, so male pattern hair distribution. So you will see women are not supposed to have beards, right? It's just something that is part of evolution. But then if a woman now develops that kind of male pattern hair distribution, then she could, not that she has, but she could have PCOS. And then the other symptoms that I mentioned, another cardinal sign is the lack of, the absence of menstruation, the absence of the monthly cycle. You understand? If it is not there or if it is regular, then it could be a sign of PCOS. My advice is for the person to go to the hospital and see a doctor. You understand? Because diagnosis of PCOS involves criteria. Do you understand? So it's not something you just diagnose just like that. It's not like malaria that you just look out, you have malaria. No. It's actually an exact sign. So you need to go to the hospital. They will take a proper history and then they will do tests and then they will put a diagnosis of PCOS and also for thyroid disorders, the same thing.
Okay, thank you for that. I hope that answers your question. Please, if you have more questions, drop them on the chat box. Also, for my question, I have one. How does insulin resistance contribute to weight gain? How does insulin resistance contribute to weight gain, acne, as well as excess hair growth?
Okay, great. So insulin resistance, like I was saying, insulin resistance means that the cells are not accepting insulin. Now, when that doesn't happen, it means that the insulin, circulating insulin is very high. And when it is high, when circulating insulin is high in the body, what happens is that it tends to stimulate the cells of the ovary to produce more of androgens and also prevents the androgens from being converted into estrogens and progesterone. And when you have more of androgens, what happens is, of course, you tend to get more of male characteristics like hirsutism, like, acne, and so on and so forth. So the insulin is just a precursor to the secretion of high level of androgens. And when androgens are high, especially testosterone, which is a male hormone. But when it is high in females, then we begin to see male characteristics in females.
Okay, I have a question outside here. If women can have increase in male hormone, does it mean that men can also have increase in women hormone?
No, it doesn't. It doesn't work like that. Sorry,
it doesn't work like that.
It doesn't work like that.
Okay. Then another question here is, why do some women with PCOS gain weight while some others remain the way they are, but still have the symptoms?
Yes. So why they gain weight is simply because of the action of insulin again, right? One of the things that insulin does is it kind of helps to store energy. And when we say store energy, we mean converting the excess energy that we take in to fat. So that is, that's just the weight gain side of insulin, because again, insulin is not it's not carrying out the function that it should carry, right? The person tends to gain weight. For some people, it doesn't work like that. Everybody is kind of different in a way, even though we are the morphology and the genetics are the same, basically, like the same whole 46 chromosomes and all that. But each of us grow through different societal and environmental backgrounds. And because of that, each of us can have certain differences in the way we kind of express illnesses. Do you understand? So for majority of people, there is weight gain, but for some people, the weight gain is not there, but they will still have the symptoms like, hirsutism and so on and so forth. So it's just the different morphology in our bodies. But generally, what happens, what causes that weight gain is insulin resistance, and everybody with PCOS has that insulin resistance.
Okay, so the question in the chat box here, someone is saying someone with high prolactin levels, irregular menstrual period, acne, or also with an ultrasound that shows PCOS, can you diagnose this person with PCOS?
Yes, the criteria are there. So once you look at those criteria, then yes, of course, once you tick those boxes, especially if you're an adult, right? Once you tick the boxes of hyperandrogenism, clinical or biochemical. Usually we choose biochemical because it's exact. So once the level of androgens are higher than normal, right? Once there's that history of infrequent or irregular cycles, and then once there's this ultrasound, that has been done, that, kind of describes the ovaries as polycystic. We also like to add the anti-mullerian hormone. So we do the test for anti-mullerian hormone, and if it is elevated, then yes, the person has ticked the boxes. Usually you just need 2 of them, but, a lot of times we tend to, be exact because of the, once we put a diagnosis of PCOS, the person's life kind of goes through a certain pattern. Do you understand? You need to do this, you need to take these medications, you need to, see your doctor more frequently than other people and so on. So, but once you've met this criteria, yes, we can comfortably put a diagnosis of PCOS.
Okay, nice. Wow, what a profound lecture. Someone mentioned in the comment chat, said, well delivered. Thank you, doctors. Thank you all. Thank you. Please, we are still open for questions. Can we bring them in? So for the men in this webinar, I hope you can see that women are really going through a lot. So when the next Model Sunday comes, show us love. Even in this month, in 2 weeks' time, I guess. In 10 days from now, please show us love. We are going through pains. Okay. So that being said, I have one question for Dr. Emmanuel. Please, can you answer this for me? When do we? What are the indications to do surgery when you have this high gluta, like you said, gouta in your slide? I think I saw a place you talked about thyroidectomy for large gouta. So what are the indications for this, please? When do you go in? Is it once someone just notice any swelling, going for surgery? Thank you.
Yeah, thank you, Dr. Sandra, for the question. So indications for surgery are quite simple and straightforward. Most times it comes or it stems from when you start developing respiratory issues, maybe because of how huge the goiter or the thyroid enlargement is. It's preventing or pressing on the trachea and affecting the person breathing. So then secondly is when it's causing digestive symptoms, you're having difficulty swallowing. So that's another issue that needs to be addressed as soon as possible. Then if you also, basically this is based on choice, cosmetic reasons. People, obviously, if your neck is closely related to your face, and most people's face are their signature points and everything. So you wouldn't want a huge mass hanging out from your neck. It makes you look awkward. So for cosmetic reasons, you would want to have that done. However, it could also be done when you have high level of the hormones circulating through your body, causing profound symptoms where you have the tachycardia, uncontrolled tachycardia, uncontrolled heat or cold intolerance, depending on which part of the hypothyroid or the thyroid issues you're having, whether it's hypothyroidism or hyperthyroidism. So if you're not comfortable with those symptoms that I mentioned during the presentation, it can also be an indication for you to seek help and get a surgery done for the thyroid condition. Is the only thing is you just have to be sure that before you go into the theater, you have seen the right specialist, the investigations are done. You must be euthyroid, meaning that your thyroid function levels must be normal before surgery is done for you. This is to prevent having an event of a thyroid storm, which could be life-threatening at the end of the day. So most times when I have patients, pre-operative reviews for patients who are going for thyroid surgeries, I will always go through all their hormonal profiles to be sure that everything is within the normal range before we give them the go-ahead to go in for surgery. Sometimes they frown about it because they feel so uncomfortable with what's happening and everything, but we're just basically saving your life and trying to avoid a very preventable complication. So
Okay.
it's important people know these things, and then
Yes.
whenever you have such encounter with your doctors, you understand why they're making such decisions.
Okay. So please, can you say this surgery, is it a minor surgery or a major surgery? Where can you classify it?
Yeah, I mentioned that. I said it's a major surgical
Okay.
procedure. So
Nice.
and major indicates that in the sense that based on the classification, first of all, surgical classification, it's a surgical risk classification more than two, so that's a major. Then secondly, the fact that there's risk of bleeding, there are risk of complications as well, complications with nerve injuries and what have you. And it also is closely related because now you have a mass at the neck. You also have, obviously, will be done under general anesthesia. So you also have a patient who is intubated with an endotracheal tube close to that same region. So it's a shared field. And whenever we have surgeries bordering a shared field, it's usually considered a major procedure, so to say. So it is a major operation.
Thank you for these slides. Quite educative. So please, a question for Dr. Chinonso here. Someone is asking, please, can you shed more light on PCOS? Is it treatable? Is it treatable?
Okay, thank you. Thank you very much for that question. So I just want to put it like this, right? It's manageable because you might be asking whether it's treatable that it will go away. But it has to do with genetics. And because it has to do with genetics, we can't change our genes, right? It's encoded down into our DNA. So it's not something that you can just treat like malaria and then forget about it. It's manageable. It's usually for the rest of our lives. It's something that is totally manageable. That means you can live a normal life and even have children. Do you understand? But it's something that you will have to manage for the rest of your life. It doesn't go away if that's what you're asking.
I hope that is a bit clear to us. Any further questions, please, can we drop them quickly so we can wrap up? Any more questions on thyroid issue, on PCOS? Okay, I think someone is typing. 1 minute, please. Okay, you know, wait, someone is Okay, one is saying, does spraying perfumes on your neck region affect the thyroid? Nice one. Me, I want to know. Please, Dr. Emmanuel, you have the floor.
So that's a good question. Yeah, it doesn't necessarily affect the thyroid gland. Perfumes now, yes, even though they are chemicals, they are not known to cause or known to have any effect on the thyroid gland. However, like we mentioned, you have to be careful with exposure to radiations. And again, I know of people who use unorthodox scents, maybe natural scents or what have you. So if you have something mixed with all those goitrogens that could inhibit the thyroid function, possibly yes. So I can't give you a straightforward answer about that because it's an unexplored area. But from what I know, spraying perfumes will not cause or cannot cause thyroid conditions. It's not a form of radiation. So don't worry about that. You can go ahead and spray your perfumes.
Okay, Dr. Emmanuel, while you have the floor, please can you give us final words on thyroid disorders and how to also avoid this, preventive measures, and just a brief 2 seconds final words, okay?
All right. Thank you, Dr. Sandra. So just to end this part of or conclude the talk on thyroid disorders, like I said, we are using this platform to create awareness. From what I presented, you saw that over 200 million people are suffering from this condition. However, 50% of that number are not aware of it. And that's even in the developed areas of the world. Then when we come down to undeveloped or these parts of the world, you know that with our health-seeking behaviors, it's quite good. The number is going to be like triple that. So it's important we understand the risk factors. Just like Dr. Chinoso mentioned, it's more genetic predisposition. So if you, and it's quite clear, you would see your aunt or uncle or father or mother or someone who had a mass on their neck. That should raise a high index of suspicion in you to, okay, let me be checking myself regularly. Let me go to the hospital. Let me even find out why did my uncle or my father have this thing, even though it might not be disturbing them most of the time. So you need to be more health aware. I say one thing, the reason why thyroid disorders are not causing a lot of mortalities is because it affects women more than men. And you know for a fact that women have better health seeking behaviors than men. If it was affecting men, trust me, you will have more mortalities and morbidity. No, this is for real because if you look at it, if you look at cardiovascular diseases that affect men and women, you see the numbers. If you see the numbers of people having stroke, maybe it comes from our masculinity or the fact that we don't agree that nothing can happen to us, so we keep on shoving things away and stuff. But women are very detailed, they are very attentive to everything about them. Every little thing that comes up, they are rushing to the hospital, even if it's not something to be bothered about, but they're rushing to the hospital to get insight on what's going on with them. So because this is a condition that is more predominant in the females, you see a lot of them managing it properly as opposed to if it was, affecting the males more. So just like I said initially, we need to make sure that we watch our diet, try to ensure that we take iodized salt because this part of the world, we are on that area where you have endemic goiter because of the iodine deficiency. And you know that most times when you go to buy your salt in the market, you see that they indicate that it's iodized. So it's important you make sure that your salt, your water is properly supplemented with the right amount of iodine. Too much of it also can affect the thyroid gland as well. Then stress levels needs to be controlled. Exercise in both conditions, exercise is also very important, it's paramount. Then you also have your regular checks. If you're going for any radiological investigations, asked to be protected. I'm sure they would do that. We healthcare workers would obviously provide you with the right protective gears, for your thyroid gland and other important glands as well. And whenever you have symptoms that looks like what we've talked about, especially for the thyroid gland, report to the nearest hospital and have a doctor properly screen you and do the right investigations, make a diagnosis. So please, early recognition is important to ensuring that you can manage this condition. It's not a death sentence. So, but if you do the right thing early enough, you will have it under control. So thank you so much for listening.
Thank you, Dr. Emmanuel. Please, can you tell us how we can reach you? Should we have further questions or want to come and have ourselves checked for these thyroid disorders we talked about today? Please, your number or email, however we can reach you.
I work at Chiron ICU and Surgical Hospital. We are located at Oshodi, Federal Neuropsychiatric Hospital, Oshodi, Old Nightel bus stop. We have our website, so you can reach our website, www.chironhospital.com. Then we have our front desk line, which I shared on my slide, or I can also, I think they're on this platform, so they're going to drop the contact details. You will call in and book an appointment with a specialist endocrinologist, or if you have any other health conditions, you can call in and have yourself checked by the specialist as well. So, yeah, we're here to serve you whenever you need us. We're always available. We're 24-hour hospital. So we're here to definitely render
Thank
care.
you. That's the ministry we signed up for. So thank you so much for your warm introduction and all. So please, can we have the Thomas on the ground? There's the last question for you that says, how does one manage weight gain associated with PCOS? How do one manage weight gain associated with PCOS? So that we can know before we start doing BBL and all that.
So that we can know before we start doing BBL. Thank you very much, Sandra. Thank you for whoever asked that question, right? Please, weight gain, I like to say that weight gain is an energy something. So if you are gaining weight, it means you are taking in more energy than you are expending. Right? Is a simple mathematical formula. More energy than you are expending, you are going to gain weight. If you are expending more energy than you are taking in, you are going to lose weight. So if you want to lose weight, it means you need to expend more energy than you are taking in. So that means regular exercise, a good exercise regime, as well as healthy dietary patterns. So your diet needs to kind of change and be more focused on things like whole grains, things like lean protein, vegetables, fruits, and all that, because those ones don't have so much energy, right? And then by the time you do exercise, you are increasing your energy output, and as against your energy intake. And that is how you lose weight. It's not a one day something. It's actually a program. It's actually something that you do and get used to, and it happens over time. Because, we are in our world today, we are so technologically savvy that we want things happening this fast, and that's how BBL came, to be a thing. So in this case, because of the whole hormonal complications that are going on, BBL is not advisable. It's advisable that you put in the work and you do it in a healthy way, right? So just to wrap up, I would say thank you everybody for listening. PCOS is a thing. Right. A lot of us as doctors, because there are so many conditions, right? A lot of times, it requires for us to read it and research it like this for us to kind of broaden our perspective on it. So PCOS is a thing. People are living with it. In this part of the world, it might go underdiagnosed because of our healthcare system, right? But you have this knowledge now. You can actually talk to somebody else if you know that they have these, they are facing these challenges. Let me put it that way, or they're having these symptoms. You tell them to go in and talk to a healthcare professional that could actually give them the right diagnosis, right? And I just want to say, as a form of wrap up, that NEM Health is here to protect your health. That's what we do. We are a national HMO, and our kind of our mission is to ensure that people have healthcare that they can trust, that you don't have to worry about your healthcare. Is, when you take away the worry of how much will I pay when I go to the hospital, it really takes away a burden from you. And we're available on our website, it's www.nem-health.com. We are also available on social media. I'm sure we are available on Instagram, on Facebook, on TikTok, and so on and so forth. And our contact care numbers are on our website and on our mobile app, so you can reach us. We are here for you. We are here to protect your health. Thank you, Dr. Sandra. Thank you, Dr. Anahe.
All right. Thank you all for listening. Thank you for your profound lectures. I think I'm going home with a lot of new knowledge today. So well done. Well done, everyone. So with that being said, is there any more questions coming in before we call it a day? Check I'm having. Okay. There's a question for Dr. Emmanuel. Do your hospital do HMO? There's a question for you, please.
I believe they do. I believe we do.
Okay. Yes. So please feel free to go have yourself checked. All right. Thank you all for coming. Thank you for giving us your time and listening and also sharing your questions and concerns. We're happy to have you till we meet again. Please have a lovely day.
Yeah. Bye. Thank you.
Bye.
Thank you. Thank you, everybody.